Welcome to this next bit of the interview, and we're finishing on a real high. And one of the real characters and one of the biggest high-profile names we have in European and, in fact, world epilepsy has agreed to give us his time today. Professor Torbjorn Tomsson comes to us from Sweden with a long and rich history, not just of his research in epilepsy, but his advocacy work and his work in mentoring and helping his colleagues. Torbjorn, thanks very much for coming along and giving up your time today. It's an absolute pleasure to have you here. We're hopeful that we can get some nuggets to help us look behind the scenes at our experts in epilepsy and give some tips and tricks for our junior researchers and see exactly what can help them in their career. So thanks very much for coming along today.
Thank you.
One of the questions I always ask people when we have here a long history in epilepsy, why epilepsy? Was it neurology first and then epilepsy, or epilepsy first and then neurology for you?
The very simple answer to that is no one else wanted to work with epilepsy in the hospital where I was. A slightly more complete answer, maybe, is that I consider myself a poor neurologist, in that I'm more interested in treatment than in diagnosis. And you know, when I started my training in neurology, which is many, many years ago, there weren't many areas in neurology where you had effective treatment. Epilepsy was one. Headache at the place where I worked was full and busy, occupied. Parkinson as well. So epilepsy was there, and it's not just a joke. It's rather truth that it was not really an area where people were interested in getting involved. So I think that was the reason, and I also found that you know, with just a little more knowledge of the medications that we had and how to use them, you could make a difference.
And when you look back at that, what has kept you most enthused, happiest in an epilepsy setting? What is it about epilepsy care that interests you and keeps you involved?
That is a difficult question. I'm not sure I can answer that. I mean, some of the more rewarding activities are to engage in bringing women with epilepsy to successful pregnancies. I mean, given the historical prejudice and things like that, and I think that's the most rewarding. I mean, that would strengthen the person with epilepsy, the woman with epilepsy, to go through a pregnancy, give birth to a child, and I think these are very rewarding.
And when you look at your time in epilepsy, I'm interested in this description that actually way back in neurology you saw an area of unmet need, and then once you were involved in epilepsy you saw areas of unmet need that you felt needed to be addressed, and that seems to be key, keeping an eye about you that you can see where things need to be covered a bit better, keeping curious, keeping motivated.
Yeah.
Yeah.
I'm not sure I saw the question in
No,
what
it
is it?
was a conversation
It's
piece.
a conversation, okay.
What about mentorship in neurology? Who would you see has given you some mentorship and left you with some skills and some attributes?
Okay. Well, there are two aspects of this, I think. So I trained in neurology. I had a good head of the department that was a headachologist,
Right.
but encouraged people to do other things as well. And then I took some training in clinical pharmacology also, where I was given the chance to be in a very dynamic environment, which I think also helped a lot. And I would also say that I was rather young when I went to my first conference and congress, you know, and I found that the epilepsy community, the colleagues, were extremely welcoming. And I think that really made a big difference. You feel that you're welcome in a community that inspires you to go on.
It's really interesting. That's come out in a number of these interviews, the sense of community, almost family within the epilepsy world. And I think that's something that's not at all changed in the last 30 years in my experience. It still remains the same. Everyone's very inclusive. And it strikes me that that sets it a wee bit apart from other neurology subspecialties. Would you agree with that?
You know, I haven't tried them to the same extent as epileptology. But my guess is that in epileptology, and I saw that in the conferences that I attended, they're multidisciplinary, and you have people from all sorts of fields that contribute, being treated equally. Yeah. Which I'm not sure you have that in some other areas in neurology, but I may be wrong. I'm not the right person to judge on that. I
think you're absolutely right, and I think the way that epilepsy reaches into clinical pharmacology and psychiatry and genetics, and of course the marriage with pediatrics and adult neurology, very important as well.
Well, I would add also social workers and psychologists and you know, you name them all, and they all seem to be welcome, and they all contribute.
One of the other ways that you've contributed to is looking around the issue of SUDEP. Would you like to tell us a wee bit about that and what way the need is underserved and where you see things going in the world of dealing with SUDEP and helping SUDEP as an issue with epilepsy?
I think this has an interesting history in a way, because there was an era, if we go back like 20 years or so, and even further, there was an important message that epilepsy was a normal condition. They were suffering from the old-time prejudice, and the main message that we were supposed to convey was about the normality of having epilepsy. We were not supposed to talk about the dark sides, like the fatal seizures, which only I think started in about 20 years ago or so. Actually, I took a look at PubMed publications as a reflection of this, starting from '94 up to now, and you know the annual publications went up from the odd one or two in the mid '90s to 200 or so nowadays. And I think it has to do with the fact that we were so eager to convey the message that of the normality of having epilepsy, and therefore we're afraid of touching on these more severe dark sides. Fortunately, this has changed because we have an obligation, of course, to do what we can to reduce the risks.
In the UK, it did strike me that the push towards being more open and proactive about SUDEP largely came from the patient organisations, and I don't know if that's mirrored in other European countries. Would you agree with that?
You know, the Epilepsy Bereaved organisation in the UK, I think, was extremely influential, and I would have wished that we had similar organisations in other countries like my own. I think also that they have been able to internationalize themselves.
Yes.
But I think both from that bereaved organization, the patient organization or the relatives organization, they've been instrumental, but there's also been scientific initiatives from the UK with leaders like Lina Nashef and what she did in the mid-90s to increase the awareness. This was also interesting in a way that it was a very welcoming group. I was on my way to shift focus in a way in my interest in epilepsy. I thought I would be more interested in the really hard outcomes rather than seizure counting or quality of life estimates, and mortality and the prevention of mortality came up as one. Another equally important outcome is the outcome of pregnancies. So both these aspects attracted my attention then in the 1990s, because I thought we should go for the really hard outcomes.
I get a sense that in the epilepsy community there's much more optimism and forward-looking now than there was 20 years ago. Would you agree with that, or am I being overly optimistic?
I'm not sure. I'm not sure. You know, when you get very much involved, I don't think you see that broader perspective. I'm not sure. Are you talking about physicians? Are you talking about patients?
Both, actually.
Yeah.
I get the feeling that now our patients are more involved in helping to frame the discussion and force the agenda.
Yeah, that's true. That's for sure. That's true. But I think this is not unique for epilepsy. I think this is a change that we see in medicine for the good.
Yeah. But I'm interested that actually when I look at your two main pillars of interest, both in SUDEP and in Europe, these are both ones where patients have often forced the pace of change very effectively.
Yeah, I would say in particular for SUDEP.
Yeah. When you look at your career, obviously one of the main pillars of your career has been your influence in and around organisations like ILAE and work around classification and terminology and policy. How would you encourage your junior researchers to get involved in that aspect of work? What advice would you give them to open those doors?
First of all, I would question your description, because I don't think I've been very much involved. I've been involved in the league, but not to the extent that you suggest.
Modest as ever.
You know, if I try to think of what I did and what motivated myself, and to transform this into recommendations for the young people, if I'm in a place to do that, in a way it's very, very simple. You should focus on what you think is interesting and what you think you can, in areas where you think you can do something. Motivation rather than career seeking.
Yeah. And that altruism will always...
I don't think it's altruism. I think that's also two kind of description of that. I mean, it's very selfish. You do what you like.
Okay.
And the thing is, the good thing is if others can benefit from that.
And when you look back at your career, any regrets, any projects left untouched or paths left unwalked? Anything that you wish you'd done maybe differently?
I'm sure. But I'm not sure how to answer it. I am. First of all, it may sound strange, but I haven't seen this as a career, and I never sort of planned my career. I've been fortunate to work with what I think is fulfilling and fun, and I've been extremely fortunate to do that with colleagues that are exceptional. And I can have no regrets in that. I've been extremely lucky. So.
And when you looking on, and would there be any particular advice you want to give to our junior researchers? Anything that you would say in terms of where do you think the big avenues are for improvements in epilepsy care in the next 20 years? What do you see as the big inroads to improving things for our patients?
I think we see it to some extent in the development when it comes to Pharma's interest in more specific epilepsy syndromes, and so we've been working with the pharmacotherapy based on trial and error, but now we get more specific diagnosis, and learn more about the underlying mechanisms, and we get more and more of specific drugs targeting specific mechanisms, and I suppose this is something for young doctors to engage in, because you always need good clinicians to contribute to that. Otherwise, it's I think it very much depends on where you are. I mean, you have different resources in different centers. If I have any advice, it would be to look at the resources that you have where you work and that are unique, and where you, with your center, can make unique contributions. In particular, if you find good mentors that can encourage you in pursuing that.
And when you look at, again, your involvement in the last 30 years around epilepsy, one of the themes that keeps coming through is the ability of the Nordic countries to utilise their database information. That's been such a bonus to the epilepsy population. And was that all politically driven? Do you think the politicians decided on this, or do you think the medical community forced this on them?
That I don't know. And first of all, I would say that, there are others that have utilized these registers for epilepsy more than I have. But they are a unique asset, and they are beginning to be utilized more and more. And I think to a clear benefit for patients. I'm not sure where the decisions came. It's you can go back some centuries, some 5 centuries or so. We were registering everything in our country during the 16th century.
Wow.
So it's a tradition of keeping record, which may in some parts of the world sound threatening. But I think that is a tradition that has been transferred into these databases as well. Whether it's a political decision or not, I'm not sure. I think it builds on a tradition.
Right, it's interesting. Right, historical move. Okay. Well, listen, thanks very much for your time today. That's been very open. One of the things that's always struck me over the last few decades is not only are you heavily involved, but this sense of fun has always come out whenever you've been at conferences. What do you think of these international conferences? Are they things that you enjoy, or do you dread them?
Do you really want an honest answer?
Yes, I do want an honest answer.
Okay. I used to enjoy them.
Right. Okay. And there's always that D4-5 effect where you think, I think.
But I think there are several aspects of this, and of my answer also. I feel that I'm far too engaged in this, considering my age, and I think we should do what we can to give more room for the young people.
Yeah, I think that's it. And of course, this is the whole point of this, to try and give some points and tips and tricks. And we need to make sure that we're encouraging, both in terms of breadth and in age and geography as well, some better participation in ILE. Listen, so thank you so much for that. It's been honest and engaging and light-hearted as always. So thank you very much.
Thank you.